Hello. In this 10-minute presentation, I'll be talking about the respond pillar, work we broadly describe as cluster detection and response. I'll hit some of the main points, and we can get into further detail during the discussion section. I have no conflicts of interest to report. First, a few key points about cluster detection and response. Cluster and outbreak detection allows us to identify when and where HIV is spreading quickly and work to stop that spread. The presence of a cluster or outbreak indicates gaps in our prevention services, which we must address to improve access to services such as ART and PrEP and stop transmission. Cluster and outbreak response uses traditional HIV prevention approaches in a more focused way. It's important to note that the four pillars are not isolated activities, but rather support each other. For example, cluster and outbreak response is a strategy that is critical to guiding other prevention strategies, helping programs identify where these other strategies are most needed. Cluster detection shines a light on populations and networks that aren't being effectively reached by existing prevention activities. Doing so allows cluster response to help programs identify where prevention resources need to be focused. Clusters and outbreaks can be detected in a number of ways. Often, healthcare providers or community members will notice an increase in the number of cases or a change in the typical demographics of HIV in the area. An outbreak of HIV in Massachusetts was first detected by a provider at a local health center who notified the health department. Partner services can yield important information about transmission clusters as well, although it is limited by the completeness of partner elicitation. The 2015 outbreak in Scott County, Indiana, was first detected through partner services, as was a recent outbreak among people who inject drugs in Seattle. Health departments and CDC can also routinely analyze trends in diagnosis data to systematically identify clusters of increased diagnoses in a geographic area or certain population. This is particularly useful in areas with small populations or low HIV burden, and for identifying clusters among people who inject drugs. We refer to clusters identified through this approach as time-space clusters. Recent clusters in West Virginia, Philadelphia, North Carolina, and Northern Kentucky and Ohio were detected through time-space approaches. And a fourth approach, the analysis of molecular data from surveillance, allows us to identify clusters of related infections. CDC and health departments can routinely analyze molecular data to identify clusters of rapid transmission, and molecular analysis can help identify the full scope of an outbreak detected through other approaches. Most data used for cluster detection come from the US National HIV Surveillance System, a robust and comprehensive system for monitoring the burden of HIV. Providers and laboratories report data from clinical encounters to state and local health departments. Data are then submitted to CDC without identifiers. And these data are used at federal, state, and local levels to prevent infections, improve care, and reduce disparities. So once CDC or a health department identifies clusters, what does cluster response entail? Cluster response uses traditional HIV prevention approaches in a more focused way. At a network level, it is important to investigate and intervene. The first step is identifying the entire network to reach people in the network who are outside of the cluster as it was originally detected. This can be done with longstanding public health approaches such as partner services or approaches such as social network strategies. As people are identified as part of the network, it's important to help them access services, including testing, PrEP, syringe services programs, and linkage to HIV care. Response to clusters may also occur at a larger program level. Ultimately, a transmission cluster is evidence that our prevention services have not adequately reached a network. We must use this information to identify and address gaps in programs and services. Now I'd like to spend some time discussing an HIV outbreak among people who inject drugs, or PWID, in Cabell County, West Virginia, because it offers a tremendous example of the power of cluster response in focusing other interventions. The 82 diagnoses in this outbreak represented a more than 20-fold increase over the prior baseline of 2 diagnoses per year among PWID in Cabell County. This response was a joint effort of the state and local health departments and CDC. And as the outbreak unfolded, we implemented a wide range of activities in all 4 EHE pillars. I'll start with Respond pillar activities, which included working closely with state and local staff to critically review information about cases and the services available in the area, and set goals for the response. Respond pillar activities also included engaging the general public, community organizations, and healthcare providers to raise awareness, provide updates, and discuss opportunities to support their response. This collaboration and coordination allowed us to rapidly implement many prevention and care interventions simultaneously with contributions from many groups. Activities related to the diagnose pillar were a focal point early in the response due to concerns that many cases had not yet been detected. This included expanding the reach of HIV testing events and the use of rapid HIV testing. The response also included surge capacity for partner services, and over 600 contacts were reached, with numerous small testing events held in jails, community centers, and residential areas as well. The response also included expansion of HIV testing in clinical settings frequented by people who inject drugs, such as substance use disorder treatment facilities and emergency departments. Treat pillar activities focused on improving linkage to care, retention in care, and viral suppression. We started with access to care, making sure that case managers were fully engaged and equipped to work with PWID. Then progressed to enhance care coordination within a clinic and expanded that to involve health department staff. And we also improved linkage to medication-assisted treatment, or MAT, for people with HIV. By December 2019, viral suppression among outbreak cases had increased from 16% to 43%. For the prevent pillar, we rapidly expanded access to PrEP and the syringe services program. Knowledge of and access to PrEP were low in Cabell County at the start of the response. Response staff trained more than 100 providers and helped with implementation. Multiple approaches were used to increase enrollment and use of the syringe services program. A newly implemented social network strategy reached nearly 200 people with HIV testing, education, and enrollment in the SSP. And overall, SSP enrollment grew from 366 to 900. Here you see the activities from all 4 pillars, all of which were critical to this response. But the Respond pillar is not only about these large outbreaks. The intensity of our responses can vary along a spectrum. On the one hand, there are a smaller number of very large clusters like the West Virginia one. These are more commonly, though not exclusively, related to injection drug use and more commonly detected through time-space analysis. Responding to these clusters requires surge capacity and often requires major scale-up of services, which can help to advance needed programmatic changes. On the other hand, there are a larger number of smaller clusters. For example, we typically detect approximately 100 molecular and time-space clusters of concern each year. These clusters are commonly related to sexual transmission and more commonly detected through molecular analysis. Responding to these clusters, particularly for moderate and high morbidity jurisdictions, requires building and staffing a routine program to manage multiple clusters that might be occurring at any one time. Responding may require scale-up of services and can help to advance needed programmatic changes. And this work also involves fundamental needs, such as infrastructure and capacity for detection, procedures and fiscal mechanisms for response, and communications and policy capacity. We have gained a tremendous amount of experience with cluster response in the past few years. However, we're still refining our answers to a number of scientific and programmatic questions. For example, how do we best identify clusters where potential for impact is greatest? This includes refining methods to account for issues that impact cluster detection, such as late diagnosis and completeness and timeliness of sequence and other surveillance data. Second, once we identify such clusters, how do we maximize impact of cluster response? Which interventions are most important, and how do we maximize the use of available resources? Finally, how do we measure and predict impact of cluster response? What are the metrics of success when many changes are structural or strategic? CDC health departments and researchers are working to answer all of these questions. As we work to implement this activity, community engagement is critical to hear priorities and ideas, determine how we can include community partners in response efforts, and identify ways that we can partner to achieve our common goals. This is especially important for working to understand and address potential concerns and maximize the public health benefit of cluster detection and response. I want to close by repeating some of the key points I started with. Cluster and outbreak detection allows us to identify when HIV is spreading quickly. A cluster or outbreak indicates gaps in our prevention services that need to be addressed to improve access to services and stop transmission. And cluster and outbreak response uses standard prevention approaches in a more focused way. Thank you.